Thank you so much for joining this briefing today. I'm really excited about what we have in store. I am Dr. Diana, aka Denny Fishbein. I work at the University of North Carolina in Chapel Hill at the Frank Porter Graham Child Development Institute. I'm also part-time research faculty at Penn State University, and I'm the co-director and founder of the National Prevention Science Coalition to Improve Lives. And it is that organization, the coalition, that is the primary sponsor of this briefing. We founded it about a decade ago as the first organization in the United States to translate knowledge and practices that have been amassed in the prevention sciences into public health policy. And we quickly grew into an organization with over 1,000 members with expertise from across a wide spectrum of disciplines relevant to prevention. We work at the national level to inform Congress and federal agency officials about the science and its relevance to public policy. And we also work with states and local communities to encourage and guide the implementation of preventative measures. So this briefing is going to focus on what the science of prevention has shown to be effective in combating our current opioid epidemic by disrupting pathways to substance use in young people before they begin to use. This approach is in part a continuum of care, including more tertiary measures, such as treatment, to address problems that have already become entrenched. But the science suggests that primary prevention should be prioritized to make a real dent in the problem. The evidence, some of which will be presented today, is compelling that a more balanced approach between treatment and prevention will be the best, most effective use of the settlement monies, and that the greatest gains can be made by building community-based infrastructure to support delivery of well-tested primary prevention strategies. So just quickly, I wanted to share some figures regarding the extent of substance use in adolescents. As you see here, in 2023, over 30% of 12th graders have used at least one illicit drug in the past year, and 14% have already started to use opioids, including prescription drugs. That's quite a staggering figure. And overdoses are on the rise, according to the CDC, by 109%. And if you look at this figure, by age 18, 12% of young people age 18 have reported severe substance use disorder. And of those with severe substance use disorder, they all had substance use disorder into adulthood, including prescription drug use within that subset. Okay. So all told, substance misuse is estimated to cost, and I'm going to give you a different figure, $373 trillion each year. And the reason why these figures are different is because the one on the screen doesn't include all the healthcare costs, the lost productivity and revenue, and criminal justice costs, just to name a few. An example is the impact of the child welfare system. About 1 in 8 children ages 17 or younger are living in households with at least one parent with substance use disorder. That's 8.7 million children. And they are at increased risk for maltreatment and subsequent child welfare involvement. As parental substance use disorder is a major risk factor for eventual SUD, in the child, services for these families are critical, and yet they're the least likely to receive them. So there's a need for us to do something different or additional because the prevalence of these disorders remains unacceptable. And quite frankly, it's perplexing because we have effective interventions at our disposal. The problem is that we have not yet made them widely available. So we're missing opportunities to intervene early before substance use has become entrenched and to break the cycle of addiction and other serious problems. So there are 2 lines of defense here. One is to mitigate the effects of adversity on brain and social development and subsequent risk for substance use disorder through services and programs. But the first line of defense, in my opinion, is in our prevention playbook is to reduce the prevalence of adverse exposures and strengthen protective conditions in the environment so that children aren't exposed and harmed in the first place. The science has clearly shown that we can avoid the negative effects of such exposures on child and adolescent development. We can disrupt pathways to substance use and opioid use disorders. We can divert youth from systems involvement. We can break the cycle of intergenerational addiction and related problems. So given the substantial body of knowledge and evidence-based practices that we have in the science, from prevention science, there are huge opportunities for scientists to work with state and local officials, human services systems, community stakeholders, and providers to integrate these practices into their policies and procedures. So this is a figure from the National Academies of Sciences, Engineering, and Medicine. And what it shows is that prevention science has generated a very strong evidence base for a wide range of developmentally oriented interventions. So you can see here from early life into childhood and through into young adulthood, we have a number of genres of programs. These aren't specific programs, but categories of the types of interventions that have been generated and found to be evidence-based. And as you go down this figure, you'll see community interventions. That's a way to strengthen communities and address poverty and community violence and social isolation. And to all of this, at the very bottom, policy is absolutely key to scaffolding and supporting the delivery of these programs at scale and in a sustainable fashion. So you can see here from this figure that there are many opportunities for intervention across young people's developmental course. And importantly, all aspects of behavior and its underlying causes are malleable, and therefore there's potential to improve life course trajectories. So the successes are remarkable, but I just want to mention that the focus on interventions alone will never achieve population level effects. Ideally, what we want is for interventions to be not delivered in isolation of one another, but within a broader network of community supports, a system of supports. And the constraints to date have been the lack of infrastructure. Throughout the 3,143 counties in the United States, very few actually have infrastructure for prevention. So there's more so for treatment, and so many localities are defaulting to treatment alone. But there are opportunities with the settlement monies and other sources to establish that infrastructure for prevention. And we can tie them to existing institutions and agencies such as human services and be supported by intermediaries that can provide the necessary training, the technical assistance, the monitoring, and the evaluation services. Many of the components of such a system are already in place and can become integrated through cross-agency and community partnerships to build a more comprehensive and holistic model of practice. And the last word for me here, one final word, is that just out of principle, we should put in place what we know works to reduce substance use in the first place, but there's also a strong economic imperative. I know it's difficult to read this figure, but if you just look at the highlighting, evidence-based programs, it's just a few select interventions. Evidence-based programs have been shown to improve health outcomes and reduce costs to society, and their cost benefits vary. But this table shows that they can save up to $313 for every dollar spent. In spite of the cost effectiveness of these interventions, they're highly underused. And so the evidence clearly shows that investing in prevention using the settlement monies and other sources of funding is both fiscally responsible and effective. And so you'll never be able to read this, of course, but I just want to point this out that there are a number of resources that can help folks that are working in policy or as users and implementers and local officials and so forth. And that this list with links, with hyperlinks, will be on our website. So, housekeeping. See, I do both. I play both roles, housekeeper. So as the housekeeper, I'll say that please do feel free to use the chat. You're absolutely welcome to chat with each other and build a sense of community around this issue. We won't be able to monitor it. I do save it, and we look through the chat later in case people have put in resources, hyperlinks, important comments that are worthy of saving into a file, and we will do so. If you have questions, though, for the speakers themselves, please put it into the Q&A, and they'll address as many of them in writing after their talks. And anything that requires like a more substantive response, we will address during the Q&A. Please note that the briefing and all of the accompanying materials, the slides and resources and video recordings will appear on our website a week or so afterwards. And our website is here, and we'll continuously put it into the chat as we go on with this briefing. So thank you so much for listening to me. Now we're going to get to the good stuff. So we have experts here in the science of addiction, including adolescent pathways and preventative approaches, as well as a landscape analysis of how settlement monies are currently being expended, and then a technological innovation that guides decision makers through an evidence-based platform to determine how to achieve the greatest return on this investment. And the full bios, I'm only going to read short bios right before each speaker, will be posted on our website. So let me stop my share, and we will get on with our first speaker, who is Lindsay. Okay, hold on one second, Lindsay, while I pull up bios. One sec. Okay, so Lindsay Volo is Vice President of Health Law and Policy at the Partnership to End Addiction, and she leads the organization's policy work relating to prevention and treatment of substance use disorders. She develops long and short-term policy projects to address barriers and identify policy recommendations that are evidence-based, equitable, grounded in a public health approach, and advance the organization's mission of informing addiction. So Lindsay, if you are able to share slides, and you already have. Okay, take it away.
All right, great. Thanks, Denny.
Absolutely.
Good afternoon, everyone. I'm so grateful to be part of this discussion today. So as Denny mentioned, I lead the policy work at Partnership to End Addiction, and our policy work is really focused is really centered around ensuring that policymakers utilize public health-based approaches to the addiction crisis, including making sure the opioid settlement funds are used within that framework. So these are the key elements of a public health approach, and I'll go through how each of these applies to the opioid crisis. It's particularly important to remember that when it comes to addiction, we're really in this moment where we're shifting from a criminalized or punitive approach to a public health approach. And this is a really seismic shift in how our country addresses addiction. So the first element of a public health approach is defining the problem. And this is actually really important with addiction because historically, we have defined the problem of substance use and addiction as a moral failing, as a character flaw, lack of willpower, or personal responsibility. And it's really this framing that's led us to adopt a punitive or criminal approach to substance use and addiction. And so that approach, the war on drugs, has largely failed. And in fact, it's really exacerbated the problem because it hasn't address the problem for what it is. Addiction is not a moral failing. It's not a character flaw. It's not due to lack of willpower. It's a disease. And we know this from extensive neurobiological research showing the impact of substance use on the brain. So looking at the scope of the problem, and Denny showed some figures in her intro, drug overdoses have really increased dramatically throughout this century. The most recent data from the CDC, which was released just last month, predicts a slight decrease in overdose deaths for 2023. And that will be the first time there's been a decrease since 2018. But the overdose rate is still incredibly high. More than 100,000 people are dying every year. That's nearly 295 people each day in 2023. That is an absolute tragedy. The dramatic rise in overdoses have been caused by opioids. First prescription opioids, then heroin, and now fentanyl and other synthetic opioids, which are highly potent and deadly and have sent the overdose rate soaring as those substances have infiltrated the drug supply. The second element of a public health approach is identifying the risk and protective factors. As you can see, there are a number of factors that really contribute to an individual's risk for substance use. They're varied, they're complex. Having these risk factors does not necessarily mean that an individual will experience a substance use disorder, but we know they make individuals more vulnerable. Family history is a big one. It accounts for about 50% of an individual's risk, and adverse childhood experiences are another significant risk factor that I know Ted will be covering more in his remarks. Age of first use is also very important in determining an individual's risk for developing substance use disorder. These graphs show the odds for developing alcohol use disorder and marijuana use disorder are 5 and 8 times higher, respectively, for individuals who first try alcohol or marijuana at age 12 versus those who wait until 21. And so this is why it's particularly important to delay use in early adolescence and really for as long as possible, because the harms associated with substance use increase the earlier that an individual initiates substance use. And that's due to the impact of substances on a still developing brain. Now for some good news. Research shows that protective factors can counteract these risks. Many of these focus on healthy youth development and really building resilience, which is a group of coping skills, social and emotional skills, coping skills, having a sense of purpose or mattering. And the other good news is these not only protect against substance use, but also a number of other negative outcomes that can affect youth. So this is the science of prevention, right? Denny just described this as sort of the first and second line of defense. But the science of prevention really comes down to this fulcrum, reducing risk factors while increasing and bolstering the strength of protective factors. So we know that having one strong, heavy protective factor, like having a trusted adult mentor in a child's life, has the ability to offset the effect of many risk factors. And so while we might not be able to change a child's family history or erase previous adverse childhood experiences, we can support them in ways that can help tilt the scales back in their favor. So as we move to the next element of a public health approach, strategies to address addiction, there is more good news. We do know what works with respect to preventing and treating substance use and supporting individuals in recovery. And it involves a comprehensive response with evidence-based strategies along this full continuum: prevention, treatment, recovery supports, and harm reduction. Together with a number of experts in the substance use field, we contributed to a report, Evidence-Based Strategies for the Abatement of Harms from the Opioid Epidemic, which consolidates the research evidence on effective strategies in order to provide recommendations for high-impact investments for the use of the opioid settlement funds. And it's really designed to support and empower state and local officials in making opioid settlement fund allocation decisions. And so what are those strategies? Well, starting with prevention, research shows that the most effective way to prevent substance use is with an early and broad approach, right? So interventions that start early and continue throughout the lifespan, not just thinking about substance use prevention in adolescence, but thinking about much earlier, starting prevention much earlier in the lifespan when those roots of risk and resilience are planted. And also that fulcrum, right? Both reducing risk factors and bolstering protective factors. As I mentioned, the importance of delaying initiation of use. School and community-based prevention programs and public awareness and education campaigns that are evidence-based or evidence-informed are also effective prevention strategies, as is reducing access. So for opioids, that looks like prescribing guidelines, safe storage and disposal, as well as early identification of misuse. Substance use occurs along a continuum, and so the earlier that we can intervene, often the better the outcome before the disease progresses and gets much worse. So for treatment for substance use disorder has often been conceptualized in terms of treatment setting. And so people often talk about rehab or having treatment beds, but what matters much more is that the patients offered a set of evidence-based clinical practices that have shown by the research to be effective in promoting recovery. And so treatment programs that offer the greatest number of these components have the greatest likelihood of promoting recovery. The gold standard for treating opioid use disorder is the FDA-approved medications, primarily methadone and buprenorphine. So the interventions here that are in bold are those that were found to be well supported by the research in the report. Treatment for opioid use disorder is not evidence-based if it does not include these medications. Yet, according to a recent report from the National Council, only 64% of substance use disorder treatment facilities nationwide providing MOUD, and only about 20% of people with opioid use disorder are receiving these medications. So we have a long way to go to make these medications more accessible. Behavioral therapies can also be an important component of treatment, but should not be required for provision of the medications. They can be an adjunct to the medications. Particularly, there's research showing contingency management's been shown to help with treatment retention and kind of change some of the reinforcement patterns around substance use. Cognitive behavioral therapy can help to address underlying negative thoughts and strategies for avoiding triggers. And family therapy is particularly effective for adolescents. And the family should really be involved in treatment wherever possible, which is really quite a paradigm shift for how substance use treatment has been delivered. Our organization does a lot of work around involving the family in treatment. And recovery supports are an important way to help people get their life back on track and reduce some of the risk for relapse. There's the most research around recovery housing and mutual support, but there are another of other promising recovery supports that we cover in the report. And importantly, if an individual relapses, which is common and an expected outcome of the disease, and as with any chronic disease, individuals should not be kicked out of treatment or recovery supports. A relapse signals they need a higher level of care and support so they can quickly get back into recovery. The risk of relapse and a fatal overdose. The risk for fatal overdose during relapse is very high. And so this is really a critical period when individuals need support, not to be punished or kicked out or alienated. Another important note is that detox is not on here because detox is not an evidence-based treatment. It might be a precursor to treatment, but it is not treatment in and of itself. And in fact, when it comes to opioid use disorder, the rates of relapse after detox are very high, and it puts individuals at significant risk for overdose. Harm reduction is another component of a public health approach, and it really aims to reduce the risks and negative consequences associated with substance use and to promote health and safety. Harm reduction is highly stigmatized, often based on a misunderstanding that it encourages drug use, which has been disproven by research. So there's the most research around syringe services programs, which often provide comprehensive harm reduction services to people who use drugs. They've been shown to reduce risky injection use and disease transmission. There are many barriers to these programs, mainly stigma. They are illegal in some states, but funding for the opioid settlement funds can be used for these programs. There's also a lot of research around naloxone, which is a medication that helps reverse opioid overdoses, and many states and localities are using opioid settlement funds for naloxone distribution. There's less research around fentanyl test strips or xylazine test strips, tools that can detect those types of substances and drugs. But some localities are using funds for those services. And then supervised consumption sites are the most kind of recent emerging harm reduction strategy. There's very little research in the US where they largely operate illegally. But at least one state has indicated they'll be using opioid settlement funds to operate one. So the next element of a public health approach is disseminating knowledge and bolstering systems. And I would say that this is where the public health approach model is kind of stuck and where a lot of the work needs to happen. So first of all, stigma is the biggest barrier to a public health approach. As I mentioned, we're in this midst of this seismic shift in how we think about addiction. And it's really difficult to overcome firmly entrenched and often stigmatized beliefs about how to address addiction. We're seeing this right now with an embrace of punitive strategies to address fentanyl, even though research shows that stricter penalties aren't effective in reducing substance use. The second barrier is that large systems, mainly the criminal justice system and the healthcare system, really need to undergo transformational changes to support a public health approach. In a public health model, addiction treatment lies with the healthcare system, but the addiction treatment has long been separated from the mainstream healthcare system. And the healthcare system in its current form is really not equipped to manage addiction. First, healthcare providers receive very little training, so they often lack expertise and confidence to treat patients with substance use disorder. We've removed regulatory barriers to prescribing buprenorphine, but very few primary care providers prescribe it because they don't feel equipped. Patients continue to present at emergency departments after an overdose, which is a really critical intervention point, but in many cases, they're released with a piece of paper and a phone number to call to get into treatment, which is a very high barrier for patients, for individuals experiencing withdrawal. In addition to training, healthcare providers need clinical supports to provide patients with a full continuum of care, means referrals to behavioral therapies, care management, peer support, having provider-to-provider support so that the providers can consult with more experienced and specialized providers for particularly complex patient cases, and the existence of community-based services to be able to link to those services in the community. Training and workforce development are also needed for the addiction treatment system and for professionals who are delivering prevention services to ensure adherence to best practices. Denny mentioned the importance of developing an infrastructure to really support prevention because one doesn't exist right now. And in the criminal justice system, the majority of people are substance involved, but very few receive effective treatment. And there's a very high risk for fatal overdose upon release from incarceration. So it's really important to provide care at every point along the criminal justice system. But again, this is going to take extensive training and systems change. The opioid settlement funds do provide an opportunity to help with some of the systems change. Importantly, this opioid settlement fund should supplement, not supplant existing funding. So for treatment, particularly the medications and the behavioral therapies, should be paid for by insurance programs. But there are many funding gaps, particularly around training and workforce development and other currently non-reimbursable clinical supports. Where the opioid settlement funds could be used. And these infrastructure investments will also really help to create sustainability of the opioid settlement funds. The last element of a public health approach is monitoring impact, and it's really critical to use data to determine how to spend the opioid settlement funds and to monitor and study the impact of the funds. I won't go into in greater detail because I know we'll be talking about this later on in the presentation. And finally, I want to share a few resources. The first are the principles that were coordinated by faculty at Johns Hopkins School of Public Health with input from other experts in the field, and they've been endorsed by over 60 national organizations. There are a set of 5 high-level process principles really to help state and local leaders make informed decisions for spending opioid settlement funds in accordance with the public health approach. And so they reflect a lot of what I covered today and are an important resource for those determining how to spend opioid settlement funds. And finally, we've been talking about the opioid crisis at a very high level, but as I mentioned earlier, we're losing almost 300 people a day to drug overdoses. A survey from just last week found that 1/3 of all Americans know someone who's overdosed. So we understand that people need help today. So in addition to the other work that I mentioned, Partnership to End Addiction offers a variety of educational and direct services to support families impacted by addiction. So if you or someone you know has a loved one who needs help, please visit our website at www.drugfree.org. Here is my contact information, and thank you so much for the opportunity to present to you today. I'll turn it back to you, Denny.
Well, that was excellent, Lindsay. Thank you so much for that. I love the full spectrum approach, basically from prevention, harm reduction, treatment, recovery, which is what we need, a really comprehensive system of services. So thank you so much for that. All right, next I'm going to introduce Ted Miller. He is a principal research scientist at Pacific Institute for Research and Evaluation, otherwise known as PIRE. And he's also an adjunct professor at Curtin University. He has more than 50 years of experience working as a health economist, epidemiologist, program planner, and evaluator. And get this, he has authored more than 400 books and journal articles on the incidence and costs of social ills and savings from prevention. He has also developed the problem, severity, and abatement planning models supporting government plaintiffs in opioid litigation. So the floor is yours, Ted. Thank you so much.
Thank you, Jenny. So what I want to talk with you about today is the kids and the adverse childhood experiences that have resulted from the opioid crisis and what we can do about them. And, whoa, I just skipped a slide. No, it didn't. Okay, yeah, so the most widely studied adverse childhood experiences, and there's a large literature on this, are child maltreatment, physical abuse, sexual abuse, emotional abuse, physical neglect. Things happening to your parents or your guardians. They died, they were incarcerated, they divorced or were separated. Your parent's misusing alcohol, your parent is misusing drugs, your parent is mentally ill or suicidal, or you've witnessed domestic violence. And recently we've added in other adverse childhood experiences and broadened it out. Things like exposure to community violence, racial, ethnic, or sexual minority discrimination, living in disorganized low-income communities, things like that. But I'm going to focus, and the opioid crisis focuses on the ones that are the more traditional ones. We have national data and state data from those, from the Behavioral Risk Factor Surveillance System, the National Survey of Children's Health, the Youth Risk Behavior Survey. So there's state data available. And as we think about the opioid crisis, 35 million Americans have repeatedly misused opioids. 44.5% of those misusers are women or female. 86% started at age 18 or older. 55% started at age 26 or older. Almost 80% didn't start because of recreational use. They started with a legitimate prescription because they're having an operation, because they had a tooth pulled, because they had an injury. If you know anything about most substance abuse, that looks completely different. There's a lot more females. It's a much older age of commencement. It's a different motivation. Few of these people had even previously used illicit drugs. As a result of that difference in age and functioning, many of them were married when their misuse started. They had an average of 0.8 children per person when they started misusing. And that means that there are a lot of spouses who suddenly had a substance misuser for a spouse. A lot of kids who suddenly had a parent. There were by 2019, there were almost 21 million children and young adults who had adverse childhood experiences resulting from non-recreational opioid misuse by their parents. And it wasn't just that they got an ACE from the opioid use. There were over 4 million children maltreated because of the crisis. 367,000 kids lost one or both parents because of the crisis. 480,000 had a parent in jail. Over 1.1 million had their parents divorced. Whoa, that's not good. Sorry.
What happened?
I have to get this back. Just a sec.
Okay, let me know if you need me to pull it up on my end.
Nope, I've got it. I just hit the wrong button. Let's see. There we go. Okay. One more. Why is this? One more. Okay. And what ACEs do is they harm your brain. They cause what's called toxic stress. And toxic stress actually changes the way our brain responds and operates. Children with ACEs have higher odds of smoking, of heavy drinking, of developing an opioid use disorder, of asthma, of cancer, of heart disease, of arthritis, of depression and self-harm, of committing interpersonal violence. And the more ACEs you have, the more those odds rise, and it's more than linear in its rise. As the higher the dose, the more response. And that means that even kids who would have had an ACE or two without the opioid crisis are a much worse risk with the opioid crisis. And we need to do something about that. The fortunate thing is we do have evidence-based ways to help these children and their families. That starts with screening and identifying the kids. And as Lindsay mentioned, stable adults and mentors in their life. So how do we get stable adults and mentors there? One direction is the parents. Is there a parent who's not using opioids? If there is, we can help them, we can support them, and I'll talk about that. If there's a pregnant parent there who's not using opioids, or even who is but has been put on medication-assisted treatment, there's home visitation. The most evidence-based, strongest effectiveness is a nurse-family partnership there. It visits from prenatally through age 2, and it's been shown preliminarily to work well with opioid-involved parents as well. Though it requires a little bit more intensity with the opioid-involved parents. There's peer-to-peer support groups for non-using or recovering parents. And a point I'd make about peer-to-peer groups is that the peer leaders have to be trained and certified. And it takes money to do that fairly because they're going to have to take days off work. They may have to travel. That should be reimbursed. And there should be, especially if there are people who are struggling financially, some minimum wage type compensation for the peer leaders of those groups. So there's a Strengthening Families program that becomes available as children hit middle school. And that's a very strongly evidence-based program. A lot of the way that program works is to, I'm sorry, that's a phone that's not even in this room. I'm going to shut the door. Yeah. But the Parenting Families program, to work well, has 8 sessions in the evening with the parent and the kids. They have funding available that lets them provide childcare at the session for any other kids in the family. They put out a dinner for the families. And remember, these families are stressed financially because of the opioid use in the family. And they also send home a second dinner. And they pay for transportation to and from. Those sessions work, but that funding of all that stuff to make them work is something that the feds don't fund food in prevention programs. So it really needs something like the opioid settlement funds. If there isn't a parent who's not using opioids, we've got to get one of the parents onto medication-assisted treatment if we can. We'd rather fix the family than move those children to foster care if we can. And one of the things that means is we need inpatient treatment recovery housing where a parent and their children can be treated as a unit. The kids also benefit from peer-to-peer support groups. And we've seen that, particularly in child maltreatment, we've demonstrated it's effective. And there's a lot of mental health care needs. Those identified children, once they're identified, need a case manager. And we don't want that as a child welfare person, a child welfare removal if we can help it. What I've recommended, and I've gotten some uptake from, I think, is for the younger kids, free schools to manage, funding them to have staff to do that case management. And particularly once they're school age, I'm very convinced that the thing to do is to add school counselors on 12-month appointments so that the number of school counselors in the school is larger and the school counselors who have the right training can be given the further responsibility of being the case managers. That works well because the school counselors are the focal points within the school for rapid detection and intervention with children who need help. They also have the ability to convene parent-school conferences and to say to a parent, look, we know that there's problems going on at your house. That just happens. But you're a good parent. We know that. We don't want your kid harmed. And we're willing to give them to put them into a round of group cognitive behavioral therapy for trauma, which will help them a lot. They can also, in the summer particularly, train community groups and community activists on how to detect ACEs, how to intervene with ACEs, how to adjust treatment for ACEs. And what we've recommended with settlement funds coordinated with Medicaid is for the kids who that cognitive behavioral therapy isn't enough to then go to one-on-one treatment for depression, anxiety, or for aggression. To make all that work, we also need mass media campaigns, both about what ACEs are, about how we respond to them. And the other side of that is to reduce stigma around there being ACEs, getting help for them, and about mental health help. And we shouldn't forget that there are proven cost beneficial school prevention programs. And you saw a slide earlier from the Washington State Institute of Public Policy around a lot of them. Some that I think are particularly appropriate for the opioid issue are the Good Behavior Game in grade 3, which teaches kids that there are rules and that there's a value to following rules. And it does it in ways that are fun and make a game out of it, but a game that actually works. All Stars and Life Skills Training are two of the school-based programs that actually have an evidence base specifically for prescription opioid abuse. Project Toward No Drugs is about the only high school program that's evidence-based on drug abuse. And there are college-based programs, the best of those seem to be run by paid peers. This is resources. The American Public Health Association, APHA Press, just put out a book responding to the opioid epidemic, a guide for public health practitioners. I have a chapter in there about adverse childhood experiences and responding to the opioid crisis aspects of ACEs. It does a lot of further in-depth analysis of how to do that and set it up. There's a second set of benefit cost ratios around youth prevention programs on the Children's Safety Network website. It's called Injury Prevention What Works, but it also actually includes all the youth substance abuse prevention programs because substance abuse is so closely tied to injury. In summary, ACEs from opioids have afflicted a generation of children. Preventing lifetime consequences from that exposure is essential. These children need a steadying adult in their lives. The partners of opioid misusers need help too. Prevention is going to be expensive, but not helping these children will cost a lot more because they'll have problems all through their adult lives. And it's important to remember that, yeah, we've got benefit cost ratios there, but the purpose of prevention is to salvage lives, not to save dollars. There are children, and we're the ones who have to make this right. Thank you.
Thank you so much, Ted. That was just great, bringing attention to the really primary risk factor for substance use disorder and how we can act early to prevent it over time. So thank you again. Now we're going to go to Aneri Patani. She is a senior correspondent at KFF Health News, a national nonprofit outlet covering U.S. healthcare and health policy. She reports on a range of public health topics with a focus on mental health, suicide, and substance use. For over a year, she's been covering how state and local governments are spending their opioid settlement funds in a series of text and audio stories published with NPR and CNN and other national outlets. The floor is yours, Aneri. Thank you.
Thank you.
Mhm.
I will go ahead and share my screen
Okey-doke.
so y'all can see that now. So thank you for the introduction, Denny. As she said, I am a reporter. I've been covering how different governments are using this money, and I really just want to share with you all some background about the settlements. We'll go through it fairly quickly in case folks already know it, and then some common themes that have come up as I've been reporting on this topic for almost 2 years at this point. So I wanted to start off by showing you the landing page for my series so that you know basically everything that I share with you all today, articles, databases, statistics, comes from something that we have published that is publicly available to anyone who wants it. So if you're looking for more context on anything I say or referring back to it, you can find it here, which is kffhealthnews.org/opioid-settlements. Also, to quickly establish the background that I'm sure many of us already know on this call, but the opioid settlement money is the result of, thousands of cities, counties, states, tribal governments suing pharmaceutical companies that made, distributed, or sold opioid prescription painkillers. And rather than going through each of those lawsuits, most of the companies have found a way to settle. And as part of the settlements are paying out large sums of money. This is gives you an idea of how much that is. So in total, there's more than 50 billion expected from more than a dozen companies related to opioid settlements. And these are all different deals. Some of the company names are probably familiar to you all: Johnson & Johnson, CVS, Purdue Pharma. Others maybe you haven't heard of: Endo, Teva. There are also regional settlements that only certain states are participating in. And there is potentially more settlements on the way as people are still considering lawsuits against places like Publix, the supermarket chain. Now, I laid that out for you in terms of the number of settlements because I want to point out that these are not all one deal. These are different deals, and that means there's a lot of variability. Some of the settlements have been finalized and others are still pending. For example, the Purdue Pharma case is under review by the Supreme Court, and so that has not actually started paying out yet. Others still are finalizing the exact dollar amounts that certain places will get because they're working out final details. Some companies have settled with state governments, but might still be pending in terms of whether they'll settling with a local government or a tribal government. There's also some differences between companies that have outright settlement agreements and those that have filed bankruptcy and are paying settlements as part of the bankruptcy. For example, Mallinckrodt is a company that filed bankruptcy and had a settlement as part of that. However, then they filed a second bankruptcy and actually ended up decreasing their payments to state and local governments as well as individuals who were owed settlement money. So those differences can affect how much money is actually coming out. There are different timelines. So the longest settlement today, opioid settlement today, is paid out over 18 years, but there are some settlements that are 10 years, 5 years, a one-time payment. And there are also slightly different requirements among some of these settlements about what percentage of the money has to be used in a particular way. And then there's also variation across different states about laws that have been passed or requirements on how the money is used. And I say all this just to be like, we're having this conversation today. We want to provide some guidance, some big picture ideas. But if you go to your state and say, hey, this is operating differently, or I say something and you think, I don't know, that's how it works for my state, you might very well be right. There's a lot of nuance here and a lot of differences. That being said, there are things that are pretty standardized that we can kind of talk about and use as our foundation. For most of the largest settlements, the payments are front-loaded. What that means is that the money that's being paid out in years 1, 2, 3, etc., are generally larger sums than they will be in years 15, 16, 17, so on. Another thing is that most of the settlements have a requirement that each state uses at least 85% of the money it receives for, quote, opioid remediation. And it's a term we'll talk about a little bit more, but essentially means things related to the addiction crisis. That 85% is also includes 15% for past remediation, meaning government has spent money on things related to the opioid crisis before, and now it can use this settlement money to reimburse itself. But 70%, so the vast majority of the money a state gets, has to be spent on future remediation, which means programs moving forward, expanding services, adding new services, things that help address the addiction crisis that is ongoing and current. And many of these settlements also include a list of suggested uses, ways that the money can be spent. That list is often called Exhibit E. It has over 100 suggested interventions that qualify as that term, opioid remediation. And these interventions range from providing naloxone, the medication that can reverse opioid overdoses, building recovery housing, building treatment, investing in youth prevention, so on and so forth. They are pretty broad, and a lot of the items on this list can be accomplished by a number of different programs. The other thing is this list is non-exhaustive, so it's not that governments can only use the money for the items on this list, but it is a starting point for what qualifies as opioid remediation. One last thing I would like to touch on in terms of laying the foundation of the opioid settlements is a question I often get is, what's the enforcement or oversight piece around how this money is used? First thing I should say is this is where states vary a lot. Some states have oversight bodies, have laws passed, but on a national level, the main oversight that is built into the settlement agreements is this sort of wonky legal paragraph. But what it means is that the companies that settled, if they feel that a state is not meeting the 85% requirement, spending 85% of the money on opioid remediation, then the companies can go back to court and try to reduce their future payments to that state or to that entity. So that is sort of the enforcement that's built into the settlement agreements. Of course, there can be more. So with that foundation, I want to turn to quickly touching on 5 themes that have come up in my reporting about this topic, and that especially members of the public have asked me about and that we've had a lot of conversations on. So the first is transparency. So this is actually an article that we had published more than a year ago. We worked with Christine Minhee, who is founder of a website called opioidsettlementtracker.com. If you have not visited that site yet, I highly recommend it. There's a wealth of information there about this topic. But basically, she analyzed publicly available documents, whether that was memorandums of understanding, state laws, executive orders, etc., to figure out which states were requiring some sort of report that would be publicly accessible to the average person about how they're spending this money and where it's going. And at the time, we found only 12 states had promised 100% transparency. That number has since inched up. It's now at 19, but that's still fewer than half. And there are a lot of states that have made no promises about transparency and where this money is going. Important caveat here is that there are states that, even if it's not required or promised in a document somewhere, are being more transparent, are sharing more information. So states can always go beyond their promises, but this was one way of analyzing this issue. And it has been something that community members have reached out to me about repeatedly because people feel very strongly about this money. Many parents who have lost their children see this as blood money that is resulting from individuals' deaths. And so they want to know how it's going. They want to ensure it's being put to good use. They want to be part of the decision-making process so that the pitfalls they've seen in the system that affected them or their children, that those are resolved and that other people don't encounter the same ones. This is a map we had created at the time showing the transparency promises. You can see there's a lot of gray on the map, which is indicating a lack of promise for transparency. Okay, the second theme I want to touch on is that a lot of this money has actually not been spent yet. A lot of state governments, local governments have not spent it, and there's no deadline in most places. Pennsylvania is one exception, but in most places, this money doesn't expire. So officials in charge of it, whom I've spoken with, really have said to me, we want to be thoughtful and deliberate with this money. We want to make sure we bring the right stakeholders to the table, that we're having discussions, that we're thinking about sustainability. If we start a program with this money, how do we keep it running? Are we filling in gaps? And that whole process takes time and it takes, deliberation. At the same time, there's certain folks, particularly community members, who are interacting with people who are using drugs or who are on sort of the front lines and grassroots organizations who feel that, they're seeing people die daily. More than 100,000 Americans have died of overdoses each year in the past several years. And so they're feeling an urgency they know this money is out there, they see the need for services, and they want to see the money getting out to the folks who need it. So there's this push and pull between those two sides that has come up time and again. Another topic that comes up repeatedly all across the country is opioid settlement money going to law enforcement, whether that is sheriffs, police, jails, it has been allotted to that across the country for a number of different uses. Sometimes the money has gone to buy squad cars, sometimes it is to buy naloxone for first responders, sometimes it goes to body scanners for jails or medications to treat opioid use disorder in jail. And this is a really divisive subject where folks feel very strongly on both sides. There are folks who say, law enforcement in many communities are the people who respond to addiction-related issues, and their budgets have been hit hard by the past several decades of dealing with this. So now that this money is coming in, it's only right that they be made whole with this money. And then there are folks who say, look, this approach of law enforcement has not worked over the past several decades. We haven't seen it produce the results that we wanted. So we should take this opportunity and this new influx of cash to invest in a public health approach and try something different in order to make more impact. And as I said, this is often a very divisive area. There are a few examples of collaboration where some jurisdictions have found ways to bring together different groups on this. One example of that is hiring peer specialists. These are individuals who have personal experience with addiction and are now in recovery to accompany law enforcement when they respond to overdose calls. So often, the law enforcement will get there, they will make sure the individual is revived, but then the peer specialist can be the one to ask them, what do you need? Can we connect you with food? Can we connect you with housing? If you want, can we connect you with treatment? And a lot of times that person is going to be more responsive to a peer, someone who has been in their shoes, than they are going to be to a law enforcement officer. Another big theme that has come up is the attention from businesses around this money. It's a large influx of cash, and there are a lot of businesses that make opioid-related products that want to see this money go towards their products. And this is not new, nor is it exclusive to the opioid settlement money. This happens anytime there's a large amount of money that's going to be made available to groups. So what I've heard from local officials especially is that they are sort of inundated with these marketing emails with requests for meetings to learn about their product, or an individual group wants to present at an opioid settlement council meeting about their product and how this money could help or their service. And what that has raised concerns around is if the company with the largest marketing budget will end up with most of this money, or if the companies that know the elected officials in charge of this money will end up with all the money. So I think from the community member public perspective, there's a hope and desire that there will be equitable processes in place so that smaller groups, grassroots organizations will all have equal opportunity to apply for the funds. And I think when I've spoken with local officials who are in charge of the money, they are really, interested in developing conflict of interest policies to make sure that things are fair, and when people have connections that they are not voting on applications. And a lot of them are really just referring back to established RFP and procurement processes that so many state and county governments already have in place to say, hey, when someone reaches out to us, we tell them you have to apply through the RFP, or, we have the standard presentation process everyone has to follow. And so that's how they're trying to address this attention from the business world. And one of the last themes I want to touch on, which is what we've been talking about all day today, is prevention. There is a lot of interest from pretty much everyone I have spoken with in using some of this money for prevention efforts aimed at youth. Where I think there are differences is when you talk to folks about how they want to do that specifically. There are many people who are who kind of go back to what they are most familiar with. And that's often a program like DARE, where police officers come into schools and talk to kids about drugs, or it's these one-time assemblies where someone who is in recovery comes and talks to kids about their addiction journey and warns them not to follow the same path. Or, you know, that session in health class where someone talks about how marijuana affects the brain or MDMA affects the brain, things like that. However, there's also a lot of folks, including many on these call that you've heard from today, who have spent tons of time researching what works in the prevention space and what is effective. And it's often not just focused narrowly on drugs, it is broader. It's about, you know, avoiding those ACEs, promoting the protective factors like Ted and Lindsay were talking about. And there are a lot of programs in this realm as well. And so I've seen a lot of emphasis on prevention when I'm talking to folks in charge of the money. I think what differs is how they approach that prevention. And there's still a lot of space for conversation, for understanding the research, and the fact that you all are here to do that today is wonderful. So I will end it there. Just wanted to give you that overview. But if folks have any questions, all my contact information is here. I'm continuing to cover this topic and I'm happy to speak about it anytime. Thank you all.
Aneri, thank you so much. That was really informative to know what the landscape looks like, and, you know, gives people an idea of where investments are being made, and perhaps how they could be reallocated as needed. So we're going to go now to Rayford Etherton, who is a former attorney. He founded the Helios Alliance, a group working to improve health, safety, and the quality of life using cutting-edge data analytics and modeling. They have constructed a national opioid abatement simulation platform that can be used to guide policy and spending decisions. And they have built a public-private partnership to develop a simulation model using systems dynamics in Alabama that will be made available to all cities and counties this fall. So we're very excited to hear about this. Rayford,
Thanks,
floor is
Jenny.
yours.
Yeah, thank you very much. And first of all, it's a pleasure to be here today. I feel I'm in the company of some really true experts. I've been a fan of the Partnership to End Addiction for a long time. I've had the pleasure of working with Dr. Miller in jurisdictions across the country as we have been working with folks to make recoveries against the culprits in this crisis. And I've been a big fan of Aneri for over a year as her reporting as KFF Health News. And so to give you a little background, as Denny said, I'm a recovering attorney, and we have been working since late 2017 with attorneys who are representing the victims of the opioid crisis, and have we started our work there by developing a national causation model to explain how and why the opioid epidemic unfolded over time, and how the introduction of OxyContin in 1996 actually led to where we are today, and how the events are connected and that they are not siloed events at all. We have worked after developing the national model with lawyers in the states of Alabama, Texas, New Mexico, and most recently Nevada, to help folks come up with recoveries in those states. And as the settlement dollars started to come in, it occurred to us that we could probably provide some value if we collected the experts that we've met across the country to come up with a way to make sure that decision makers had the best tools available to allocate those settlement dollars as they come in. And the core methodology that we use in our litigation practice is called system dynamic simulation modeling. And what that does, it allows people a lot smarter than myself to come up with a way to build a model that replicates, demonstrates how the real world acted over time. And then to be able to go in and simulate what would have happened but for specified events. And so that's what we did in the looking backwards space. And we decided about a year ago that we should take that same approach to looking forward, which is actually a more traditional use of system dynamics modeling to predict the impact of actions before they are taken. And so we put together a team of experts. I'm in Mobile, Alabama. We met last June, and we put together a group of national experts, which includes Dr. Miller, to come up with a way to build an abatement model, a national abatement model that could then be translated, used by smaller jurisdictions to make decisions about how best to spend abatement dollars. And we did that with the notion that it would be helpful for people to understand the likely outcome of deployment of funds, to provide a basis to measure the outcomes as those programs are being implemented, and then to identify gaps that needed to be addressed going forward. We decided that it would be best to build an organic movement, not to depend on state legislatures or other governing authorities, but to build it from the ground up. So we reached out to folks in Alabama, starting with the Porch Creek Indian Tribe, the Drug Education Council, which is here in Mobile and has been around for 5 or 6 decades, the Mobile County Sheriff's Department, the City of Mobile, to come up with an approach that would be able to take into account the local situation in a way that we could best use those dollars going forward. We were able to get a lot of actually a groundswell of support locally, which exceeded our expectations, and have with the people I mentioned, along with the Alabama Veterans Association, we have developed an Alabama abatement model that allows us to work with local regions in the state to come up with the best way to spend dollars going forward. And a lot of these people have not deployed any funds yet. And we look forward to working with them to do that. We believe that what we offer in this space that is somewhat different is to use the best technology possible to create an evidence-based, data-driven, transparent approach to dealing with the lack of uniformity about what the priorities ought to be. Ted Miller, Dr. Miller, has come up with a wonderful abatement plan that's been legislated in Nevada that deals with treatment, prevention, what we call survival programs, and then coordination and communication. But how do you balance those things? How do you combine them? What are the best approaches to use? And what we're not a crystal ball, we're not an oracle, but we are able to offer a technology that allows decision makers to take a transparent look at perhaps the best outcomes before the funds are actually deployed. I can say more about this now, Denny, but I'm happy to kind of depart and let people ask questions if they have any.
Okay, great. You've teased us. So we definitely want whoever wants to speak. If there are Q&As, I don't know if I can actually allow people to speak and be seen, but if you have something now that is for Rayford particularly, put it in the chat and I'll try and look at that. Yeah, so this is such an important platform and service to people that are trying to figure out how best to use the settlement monies. And I think that as evidence-based as we can get in terms of what we're doing, so that we're not just throwing spaghetti on the wall, but we're doing things with some wherewithal about what's likely to work. What are the best practices that have been identified as working? And I'll just stress, I did this in the Q&A, but just to stress that what is used in any given community really needs to be determined by the community.
Yes.
It's not the so-called experts. The community is the expert. They know what they're experiencing. They know what their primary issues are. And then we can guide them in identifying the tools and resources that they need to implement things at scale in their own communities. So there's no cookie cutter approach here. It's a matter of making a determination of what those needs are, and then meeting those needs with what has been developed. What Rayford has done is just truly transformative in terms of being able to guide not only the use of the settlement monies, quite frankly, but any official, any community practitioner, educator, clinician wanting to make a difference in the substance use space can be guided by the platform that Rayford and his company has developed. Jana Lee is asking for where can they find your platform? So if you or Elizabeth could put that into the chat, that would be greatly appreciated. Mm-hmm.
And Danny, I do want to emphasize what you said, is that the reason this works, we think, is that we have engaged local people. We have taken all of, and when I say we, I mean the MIT modelers, not Rayford. Yeah, they have taken all the data that's publicly available. We have relied on the work of people like Ted Miller and others across the country to come up with a national abatement model that creates an approach, if you will. And then we take that and scale it to local jurisdictions, and the publicly available data is very important, but the input from local people is just as important, because they see it every day on the ground. And that's one thing that ANERI's reporting has done for the last, from my standpoint, more than a year, to make it very clear that we need to listen to what people who see it every day are seeing and take that into account and make sure that everyone who has something to offer has a voice to be heard, and that they have equal standing for funding and a way to move forward with their mission as the traditional silos, if you will.
Right. Exactly. Yes. Very, very good points. And I'll just also mention that for all of these speakers, they all have done just such tremendous work. And to get to what they offer in terms of resources, information, tools, research, etc., we will put all of that on our website when the briefing recording is ready in about a week. And so you can go directly to their websites and get more information. I'm just going to take a quick shot at this before people disappear completely, is that our next briefing will be on cross-agency responses to the substance use crises very specifically. So keep an eye out for that. You'll be notified one way or the other that we're about to do that briefing. So one of the questions that from a listener who was not able to add it to Q&A, and I'll just, I'd like to just briefly acknowledge the importance of this question, which is, has or is any of the money going to people that have been hurt by the opioid crisis? And I would say that where it is going is to services that can that can assist these individuals directly. That is the beauty of prevention, is that the services that we're talking about with respect to prevention are going to very, profoundly, in some cases, help child development so that children can be healthy and thrive and be successful adults. And if that is in place, then they're much less likely to use substances. And so they are the beneficiaries of these approaches. Obviously, Narcan is specifically, if we make them available, Narcan is specifically benefiting people who've overdosed. All of these approaches are designed to help people. What we're talking about here is the balance of investments. How much is going to the more tertiary approaches where the problem has already been entrenched relative to primary prevention, where we want to prevent the problem from occurring in the first place. And it's all needed. Every single aspect of this spectrum is needed, but we're providing evidence that a better balance is needed between prevention, harm reduction, treatment, recovery. It's all needed, but prevention has always been underfunded. So we're, really calling attention to that. So Aneri, please.
Yeah, I just wanted to jump in to answer that question, because this is something I hear from people who are reading articles all the time. Why is the money not going directly to families?
Yeah.
And there are two parts to this answer. One is that there are a few settlements that do have direct payments to people who were affected, who lost loved ones, or who themselves were in addiction and then became part of these class action lawsuits. Those are the settlements with Mallinckrodt, with Purdue, and with Endo. My understanding is most of those have not started paying out yet. However, people who join the class action lawsuit should have information from their lawyers about, how that's progressing and when they're going to get the money. That being said, it's a very small amount. By and large, the majority of this money is going to governments, and that is a product of our legal system and something that is too long for me to fully explain here. But basically, the idea is when individual families sued and tried to hold the pharmaceutical companies liable, the legal system is not set up to really make that connection between the company and one individual and why they were connected. What ended up being more successful were the lawsuits that came later on from government entities that said this is a public nuisance affecting our entire community. And that is why a lot of the money is going to government entities. But as Denny was saying, the idea is that they are supposed to use it on services and programs that do then help the families and individuals who are affected. But it is not a direct line. And I understand there's a lot of frustration around that.
Oh, that's a perfect answer.
And
Thank you.
Danny, following up with what Aneri said, and your point about prevention versus treatment at this point, is that as we've gotten further into it, it became very clear, looking at the data that we've seen, how important it is to focus on children that are like in K4, K5, that are coming along right now. I mean, we have an opioid use disorder population, and obviously we need to treat those people, and monies need to go there to deal with those people and their families and the people who are affected. But a real impact we can make with this money is to lower the number of people that enter this bucket. And that takes education, it takes prevention, it takes very intentional programs to change the way that we deal with this with children as they progress through school. And that's a very exciting challenge, I think, for all of us, because that's a way to affect a current generation today.
Yes.
I just wanted,
Yes.
I just wanted to
Lindsay,
add,
sorry.
I just I agree with everything that's been said, but I have the benefit of being both a lawyer and a public health person, and so it's right at the intersection of these lawsuits. And so I think also litigation is a really imperfect tool, and these settlements are an imperfect tool to address this type of crisis. And so, understanding the frustrations that people are facing, that money's not going to families and people who've been directly impacted. I don't know that justice can be found through this type of agreement. And the same themes have come up in the Purdue case that's currently before the Supreme Court. So, we're using the tools that are available, but there are deep flaws in how they can address what happened in this crisis.
Right. Right. And one of the big stumbling blocks is that, as Colleen is pointing out, there's very little understanding of what prevention is.
Mhm.
And there's even fewer people understand that there's a science to it. And it's actually a very well established science for the last 40 years. And it's very substantial. It's a subdiscipline of public health. And what we need to do is be better narratives.
Yeah, Denny,
Narrators, excuse
so
me. Yeah.
you're very good at this. So how do we get people on the same page in terms of trying to have a comprehensive approach that does use science, that uses data, that uses evidence, and that we do it on a national basis? Because that's, I mean,
yeah.
That was not a rhetorical question. I don't know.
No, that's the whole reason why I founded the National Prevention Science Coalition to Improve Lives, is to get that information to the public and policymakers and practitioners and so on. And, it has been challenging. We go down to Capitol Hill and meet with legislators on a regular basis. And one of their first questions is, what do you mean prevention? Do you mean Narcan? Or some other sort of tertiary measure that is not really primary prevention? We really focus on the mitigation, but even more importantly, the eradication of the risk factors, the root causes, not just waiting for the problem to become entrenched, as I said before. And so it has been, we have a knowledge mobilization committee that grapples with these issues and attempts to create narratives that will help to reach a wider audience. I would strongly suggest anybody look at the Frameworks Institute in Washington, D.C. that has really a very strong, rigorous methodology for framing these kinds of topics for policymakers and other target audiences. But it is something that we grapple with, and it's as if every different kind of constituent group needs a different type of messaging in order for it to really resonate with them. And so we're working we created a brief on what is prevention science. And now we're distilling it down to a one-page flyer that we can hand out before we talk to anybody and say, read this first, and have a better understanding what prevention science is. And then we can talk about the substantive issue areas of mutual concern. Right. So it's an ongoing challenge.
Jenny, I'd like to mention one other area of prevention that we haven't mentioned today, which is that the research that's coming out of the litigation is showing that these are incredibly addictive substances. And we've started re-educating the doctors, but we really haven't gotten there yet. And they keep prescribing these incredibly addictive substances. They're prescribing them in a more responsible way. But until we change the way that pain is responded to, so that they're not the first choice.
Yeah.
So the doctors really understand how addictive they are.
Yeah.
We're going to keep growing this crisis.
Yeah.
And that's a direction that prevention has to go. A second point I want to make is that, as Lindsay pointed out, MAT works, medication-assisted treatment. But the research shows that after you've had medication-assisted treatment for a year, it works just as well in the next year as it did in the last year. We tend to take the people off because it's expensive. But if we don't want them to relapse, we have to keep them on. Right. And that's expensive.
Yeah.
And it's a form of prevention.
Yeah.
Because otherwise, they're right back where they started.
Yeah. Yeah, absolutely. We need to understand what their alternatives are to opioids for even pain management. But, I just want to make a point that the addiction and dependence are different, and most people don't realize that. Right. And we have a briefing from 2019. The director of NIDA was our keynote that everybody should look at. It's on our website. But it really makes the point that there is a difference and we need to understand it. If you're receiving opioids for chronic pain management, for palliative care, cancer, cancer patients and so forth, they need this kind of powerful pain reliever just to function.
Mhm.
But addiction is behavioral and social. And that's where you get into compulsive use and where you will do almost anything to get it because your supply has gotten cut off. And so just put the briefing link in the chat. And so there are different processes, but what I would say, and I will put this out there, as a chronic pain patient, there are alternatives. There are alternatives to opioids, and I use none of them. And I use some alternatives that has helped me tremendously. And doctors do not tell you what they are. I had to do extensive research to identify what those alternatives are, and have been able to manage. So there's a lot of thorns that need to be pulled out in order to deal with that issue. But I could not agree with you more, Ted, that there are just a lot of ways that we need to hit this up, and we need to realize that what's being prescribed and the Partnership to End Addiction is potentially leading an initiative to help physicians understand the difference and to provide education in medical school about what addiction is with addiction medicine. It's a specialization that few have. And it should be, we feel it should be, a cornerstone of medical students' curricula, so that they understand it, because they all prescribe. It's a very important part of the campaign. Rayford, were you going to say something?
Well, I kind of lost the thought, except I was going to say that every legislator we've talked to, every elected official, people always want to do something.
Yeah.
They are unanimously on board to try to say, we want to help in this process. But I'm not sure there's a great mechanism out there yet to give them the tools to do that.
Mm-hmm.
And there ought to be a more, we started out with the Appalachian footprint, but there ought to be a more national consortium of something that brings people like this and the people on the call together. I've been reading them. A lot of North Carolina people are there. I saw that today.
Yes, that's because I know people. But listen, Rayford, so Jess, if you can pull this up for the chat, the Consortium to Advance Prevention Solutions to the Opioid Crisis. This is a national platform for people to really engage.
Okay.
It's an arm of the MPSC. The Partnership to End Addiction is a co-lead with us, as are two others. And so we're attempting to really pull together a collective to change policy in this regard, policy at all levels, federal, state, local.
Exactly.
Yeah. So yes, it's this way, we don't have to respond to 500 emails a day, but we can kind of reach out and say, who has this expertise? Who can, develop a coalition in this community? How can we all kind of engage around the opioid crisis and what we can do on multiple levels?
Because
thank you so much, Representative Tarvin, for joining us. Go ahead.
Because there's so much more than any group can do on their own.
Right. That's why we need a collective.
But if you get everybody together on with a shared vision, I mean,
yeah,
I think to use Ted's term, it is for the children.
Yes, it is for the children.
I mean, at the end of the day, I mean, that is what we're trying to do here.
Yeah.
We're trying to preempt another generation of users.
Right.
And then I can't even pronounce the term, but the new animal tranquilizer that was reported yesterday, that is causing overdose deaths in Detroit and Chicago. I can't even pronounce the
Oh,
name of it.
xylazine.
No, this is even MEDETOMIDINE. It's new and it's more potent. And it's just hitting the market.
Yeah.
And
See, I
that's
mean,
what
they're just
it
going to
is.
keep coming. They're just going to keep
Yes.
coming. That's why we need to look at the root causes, and we need to look at what propels children to use in the first place.
Right.
Mm-hmm.
You know,
Yeah. Yeah, because we just have one decade
I'm
after.
sorry, I know I'm preaching the choir, but
Mhm.
I'm trying to get trying to figure out a way that we can all continue a
Yeah,
conversation in an intentional way.
yeah, right, right, right. Around a common agenda on the topic. So it's 3:32. We're happy to stay on. I'm still looking at the chat, and it looks like there's a number of questions that could be addressed and we'll do what we can to address them now or later. And are there any other comments? Lindsay, Aneri, anybody that want to make any last comments?
I'm just really grateful, Denny. Thank you for hosting this. I think, these funds, as I mentioned before, they're imperfect, but they really provide a really important opportunity to invest in a problem that has long been misunderstood, mismanaged, underfunded. And while there have been more resources, federal resources in particular, going to this crisis, they've really been focused on treatment. And so while addiction has long been ignored, prevention has really been ignored. And so this is a really important opportunity to invest these funds in a way that will change the trajectory so that we're not constantly chasing the substance, but really building the infrastructure to address this more effectively. And as I said, the good news is we know how to do it. Like
Yeah.
we have, right? We know what the strategies are. We've just really lacked the political will to really commit the level of resources that are necessary to address this.
Yes, thank
Lindsay,
you.
that is perfect. Don't chase it. I mean, have a plan to address it on the front end. Don't be chasing.
Right. We've been reactive, and we need to be proactive. And Aneri, I hope you don't mind me saying this, but your work has really been instrumental in helping to direct our attention to what is happening. And we need, what you informed me of today is that sometimes it's used for measures that we don't necessarily see the connection, and you've helped to make that connection and some rationale, even if it's not in the primary prevention space. It still brings our attention to why it's needed in all of these other settings as well, why we need to expend monies in other areas as well, but not just putting everything into one bucket. And so I thought that was really helpful. And what I hope you don't mind me saying is that if you follow Aneri's work, then as constituents, you can be more active in the process of understanding how monies in your districts are being allocated. And you can be more active in the process of that decision making. Is that okay?
Yeah, absolutely. Thank you for sharing that, for inviting me today. And to the last point, yeah, I think as a reporter on this topic, I spent a lot of hours filing public records requests, calling elected officials, asking what they're doing with the money, asking what documents they can make available. And then the goal is to turn around and make that all available to the public, to people who are invested in this money and want to follow how it's used, who want to be in the rooms when these discussions are happening, who have ideas about how it should be used, so that everyone can participate. So if folks have ideas on that, if they have things that they're trying to access, I can't guarantee I can help everyone with that, but that is our overarching goal, is really to make the information available to the public.
Yeah, that's exactly right. We need to know. Information is power. Well, thank you all so much. This has been just tremendous. Again, to the audience, we will have this out in about a week, and you'll automatically receive a link. So there's no need to write to us, because you will automatically get it if you've registered for this briefing. And so I hope you all have a wonderful day. Thanks again for your attention.
Thanks a lot.
Thank you, Denny.
Thank
Take care,
you.
everyone.